Hi guys, good morning everyone. So we are starting the quiz discussion, neuro-ophthalmology. Okay. So shall we start with the first question? All of the following may be signs of optic nerve dysfunction except. Okay. So optic nerve ka functionary tests which are there. So that is the basic concept behind the question. So all of them except. Okay. Decreased visual acuity. So whenever your optic nerve is involved, the vision will definitely, there will be a decrease in vision. Yes. So decreased visual acuity is a sign of optic nerve dysfunction. So that is not the answer here. That means let's move on to option B, decreased contrast sensitivity. See, I have taught you in optic neuritis, there is decreased contrast sensitivity and it takes a longer time for it to recover, or sometimes it continues to remain abnormal. Yes, even though the visual acuity comes back. So decreased contrast sensitivity is again a sign of optic nerve dysfunction. Okay. Option C, relative afferent pupillary defect. Yes, there is always an afferent pupillary defect whenever there is an optic nerve dysfunction. Now, relative is whenever there is a unilateral optic nerve dysfunction. Yes, is that clear? Hi, Vinod. Hello. Hi. Guys, good morning, Vinod. Good morning. Okay, so that means automatically now I know option D is the answer. So what is option D? Option D is metamorphopsia. See, metamorphopsia means distorted vision. Everything is teda-meda. Everything is wavy, undulating. So if you're looking at straight lines, the lines will appear wavy. And if you're looking at some floor, a surface, it will appear undulated. Yes, metamorphopsia. Very good. Who is this? Paul, Lavraj Paul, very good. Very good. Yes, metamorphopsia is a characteristic symptom of macular pathology. So whenever your macula, not the extensive retinal problem, if your macula, definitely if your macula, even if there's a tiny lesion, there's definitely going to be metamorphopsia. So remember the double M. Metamorphopsia is seen in macular pathologies. It is not a sign or symptom of optic nerve dysfunction. Okay. So this is not a feature of optic nerve dysfunction. Right? So that means you know decreased visual acuity, decreased contrast sensitivity, RAPD, all these are signs of optic nerve dysfunction. Okay, so can we move to the next question? Lesion of optic chiasma will result in. Now, this one turned out to be very tricky for you. Okay, so it results in primary optic atrophy or secondary optic atrophy, consecutive or cavernous. See, definitely not cavernous, because cavernous means typically glaucoma. So option D is ruled out. Good morning, BU. Good morning. So cavernous optic atrophy is ruled out because it is seen only, it's very characteristic of glaucoma. Okay. Now, option C, consecutive optic atrophy. Consecutive optic atrophy, remember, it's a consequence of, or it's happening after an extensive retinal pathology. Yes. So, it is not the answer. We are talking about chiasmal lesion. Yeah, I'm coming to your comment, Vinod. Secondary optic atrophy. Many of you have gone for secondary optic atrophy in optic chiasmal lesion, thinking optic chiasmal lesion is primarily some tumor or some mass lesion pressing on the chiasma, which is correct. Yes, but and you think there will be papilledema. See, papilledema is quite rare in chiasmal lesions. Okay, the papilledema is quite rare in chiasmal lesions. That is the whole point. Okay, it's very rare. So it is not secondary optic atrophy, because what is the definition of secondary optic atrophy? Optic atrophy that occurs after disc edema, right? So when there is no papilledema or there is very rare chance of papilledema, so here it is basically an atrophy. There's definitely compression. So compression atrophy of the axons. So there is a retrograde as you said. Yes, very good. Retrograde or descending type of optic atrophy. Yes. So when we look at the pathological classification, it is a retrograde or descending, because from the chiasma it is coming down the degenerative changes, and I can see it on the optic disc. Yes. So that way it is retrograde or descending, but because there is no papilledema or disc edema, before the optic atrophy, this qualifies for primary optic atrophy. Is that clear? Although it appeared a little easy, it kind of appeared straightforward. It was not a straightforward question. It needed the concept that papilledema is quite rare in chiasmal lesions. Is that clear to everyone? Yes? Shall we move on to the next question? Champagne cork appearance of optic disc is seen in. See, champagne cork, the cork of a champagne bottle, of any wine bottle also, it's going to be a very tan color, okay, a very light brown color. So the normal color of the optic disc, which is pink, is lost and it is replaced by this tan color. Yes, so champagne cork appearance, you remember the champagne, CH, okay, it is seen in the chronic, CH, chronic stage of papilledema. Which stage of papilledema? In the chronic stage of papilledema, because papilledema we have very many stages. So it is seen in chronic stage of papilledema. Option A, glaucoma, no. Option B, Leber's hereditary optic neuropathy, no. Papilledema, yes, papilledema. Option C is the answer. Optic disc drusen. See, drusen can mimic an appearance of disc edema, but that itself is not does not qualify for calling it papilledema or anything of that sort. Okay. All right. I'll come to your questions later. Question number 4. In neuromyelitis optica spectrum disorder, antibodies are formed against. See, this NMOSD is a very, very important topic, also known as Devick's disease. Okay, but nowadays we don't even use that term. It's NMOSD. It's a spectrum. Okay, neuromyelitis optica spectrum disorder. So here there are autoantibodies formed against, as you all know, aquaporin 4. Okay, now this aquaporin 4, where is it located? It is located in the foot processes of astrocytes. Yes, where is it located? It is located in the foot processes of astrocytes. So let's see what is the answer. Option A, pericyte. No, pericytes are supportive cells present on the retinal capillaries. Not that. Myelin sheath, antibodies against myelin sheath. No. Protein and cell membrane of microglia. These are not microglia, these are astrocytes. Option D, protein in the cell membrane of astrocytes. Yes. Yes, so this protein, that is aquaporin 4, is present on the foot processes, or it is present on the cell membrane of astrocytes. Okay. So NMOSD is typically characterized by optic neuritis and also transverse myelitis. Optic neuritis and transverse myelitis. Okay, so there will be both. Yes, very good, BU. See, drusen are some calcific deposits on the optic disc. It's buried in the optic disc. So it will give an appearance of bumpiness to the optic disc. The optic disc margins will be blurred. That is optic disc drusen. Okay, it's one of the differential diagnoses for disc edema. And it because of these calcifications, on ultrasound, when you do optic disc drusen ka ultrasound, you will see the calcifications. Yes, you will see bright hyper reflective spots. Okay. Okay, question number 5. True statement regarding optic neuritis are all except. So that means we have to find out the false statement. So option A, there is 50% chance of developing multiple sclerosis after an attack of optic neuritis. See, I've told you, remember the 50-50 biscuit. Okay, 50-50, all of you know the 50-50 biscuit. Those biscuits, 50-50 crack jack and all, no? So remember the 50-50, it's both 50-50. Optic neuritis patient, 50% chance to get multiple sclerosis. So similarly, multiple sclerosis patient, 50% chance to develop optic neuritis. So it's a 50-50. So this option A is correct. We have to find out the false statement. Optic neuritis is a presenting feature in 50% of patients with multiple sclerosis. No. See, if I have multiple sclerosis, my first sign, okay, the first time I go to the doctor is because of optic neuritis. That is in 30% of patients. So if I take 100 patients with multiple sclerosis, 30 of them would have initially presented with optic neuritis, and as an ophthalmologist, I would have made the diagnosis of multiple sclerosis because there is a decrease in vision. He comes to me, I would have done MRI, I would have done obviously all the eye examination, I would have done the MRI, we would have figured out the enhancing optic nerve and also probably some demyelinating plaques in the brain. Okay, and obviously will have a neurologist referral and would have been diagnosed of multiple sclerosis. So 30% patients have initial presenting feature as optic neuritis. Is that clear to everyone? So you have to read the question very carefully. True statement regarding optic neuritis are all except. So we know option B is the answer. Okay, let's go to option C. Dyschromatopsia may persist even after visual recovery is complete. What is dyschromatopsia? Abnormal color vision. Which color is abnormal? Red initially and also green. So red-green color defects may persist. So your visual acuity starts recovering. So almost by 3 to 6 months, it comes back. Okay, comes back to whatever is destiny, kismat. Okay. But the dyschromatopsia and contrast sensitivity deficits may persist. Yes, it may persist. All right. Okay, so that is true. Option D, only steroids. You know they are contraindicated. Only oral steroids. Okay, okay, that word was missing. Okay, only oral steroids. Okay, only oral steroids. I'm sorry for that lapse. So only oral steroids increases the risk of recurrence of optic neuritis. That is why they are contraindicated. So if you have to give, you have to follow the proper protocol of giving intravenous methylprednisolone followed by oral prednisolone. Okay. So the correct option would be option B. Although last option is kind of vaguely framed, so I'm sorry for that. Alright, question number 6. All of the following are risk factors for NAAION except. What is NAAION? Non-arteritic anterior ischemic optic neuropathy. Okay, so option A, myopia. No, hypermetropia. Hypermetropia is a risk. Option B, hypermetropia is there. So we already know option A is our answer. So what are the risk factors for NAAION? Hypermetropia, anything again which can cause virtuous triad. Okay, so hyperhomocystinemia also. Okay, so similarly, obstructive sleep apnea, because obstructive sleep apnea, virtuous triad is involved in the pathophysiology. So that is also a risk factor. Hypertension, the most common cause of NAAION. Okay. So myopia is not a risk factor for NAAION. Hypermetropia is a risk factor and what we call as disc at risk. It's a crowded disc. The hypermetropic disc is a crowded disc which is at risk of NAAION. Is that clear? Okay, next question. Light near dissociation is not seen in. What is light near dissociation? So when you shine light, you throw a torchlight on the eyes. Yes, the pupils are not constricting. But when you show a near target, yes, when the patient is looking at a near target, the pupils are constricting. So there is a dissociation between the light reflex and the near or accommodation reflex. Is that clear? Okay. AD's pupil. Yes, AD's pupil, there is light near dissociation. We'll discuss that on another day. Honors pupil. Honors pupil is myotic. Yes, it's myotic. There is a dilatation lag. So when the patient is in a dark room, there is a poor dilatation. But there is no difference between the light reflex and accommodation reflex in honors pupil. Argyll-Robertson pupil, yes, there is light near dissociation. AD's pupil, yes, there is. Parinaud's dorsal midbrain syndrome, yes, there is. Okay, Parinaud's dorsal midbrain syndrome, there is a light near dissociation syndrome. Type 1 diabetes. Now, you got caught there. Say, type 1 diabetes is, there is very commonly, there is an autonomic neuropathy. Okay, there is a peripheral neuropathy and an autonomic neuropathy. Because of that, there is a light near dissociation. Yes, diabetics, not just type 1 diabetics, even type 2, if at all they get a neuropathy. Okay, they get an autonomic neuropathy, which is very high. The chance is very high in type 1 diabetics. So, in that case, you do get light near dissociation. Is that clear? So, that is not the answer. Our question was light near dissociation is not seen in. It's not seen in honors syndrome. Is that clear? Honors pupil. So, it is seen in AD's pupil. It is seen in Parinaud's dorsal midbrain syndrome. It is seen in type 1 diabetes. Clear? Okay, next question. Right homonymous hemianopia may occur in lesion of. So, right homonymous hemianopia means the right side of the patient's field. Yes, the right side, his entire right side, he cannot see. Whatever is there on his right side, he cannot see. Is that clear? So that is right. So for the right eye also, the right half, the left eye also, the right half. Yes. So whatever is here, okay, this side of my field. So if this is my center, anything here I can't see. Yeah. So that means the lesion is somewhere on the left side and it is a post-chiasmal or a retrochiasmal lesion. Yes. So whenever you have homonymous field defects, it is always, remember, homonymous field defects will always be a contralateral lesion. Yes. And it will be a post-chiasmal or a retrochiasmal lesion, meaning it could be in the optic tract, LGB, optic radiation, or the occipital lobe, that is your visual cortex. Yes, when I'm talking only about homonymous visual field defects. Now here it is a hemianopia. Okay, option A, right optic nerve. Nerve is a pre-chiasmal structure. It is anterior to the chiasma, so not the answer. Right optic tract. See, I told you it has to be contralateral. Yes, the visual field defect and the lesion are contralateral to each other. So in the question, it says a right-sided homonymous hemianopia. So my lesion should be on the left. So definitely I can't entertain right optic tract. Option C, left optic tract. Perfect, no? Left optic tract. I think that is the answer. Option D, left occipital lobe. Say occipital lobe or visual cortex should have this macular sparing. So it would be a hemianopia but with macular sparing. That is not mentioned for us. It stops with hemianopia. So the answer is left optic tract lesion. Is that clear? Suppose I have a left occipital lobe lesion. What would be my visual field defect? Please put it in the comment section, guys. If I have a left occipital lobe lesion, what would be my field defect? Okay, by that time I'll go to the next question. Physiological optokinetic nystagmus involves. See, this is very, very easy. Just imagine you are in a bus or you're in a bus or a train or a car and you're looking at the side. Yeah, I always imagine the train because as a kid you always went in trains and you looked out of the train. Yeah, so when you look out, you have to keep your eyes keep moving. Okay, it's involuntary, right? Because you're looking out. So that is a physiological optokinetic nystagmus. So what happens? So you kind of look at something, you follow it and then you come back. Yes, because your train is moving. Yes, your train is moving. So you look at something, follow and then quick come back to refix it on something else because that object is gone. So there is an ipsilateral smooth pursuit, same side smooth pursuit. To refix it, there is a opposite side quick movement, Q sound, saccade, okay, saccade. So remember, saccade is a quick movement, okay. So you have a quick contralateral saccade. So remember the ka sound, ka, contralateral, quick, saccade. Is that clear? So there is a slow ipsilateral pursuit, okay, smooth pursuit and a contralateral saccade. Yes, is that clear? Just follow. That's what I'm telling you. No, I'm just teaching you, maniac. Yeah, Vinod, very good. So in a case of a left occipital lobe lesion, we would get a right homonymous hemianopia with macular sparing. Very good. So got it? Yes, I just explained better. Yeah. All right. Next question, which of the following is considered as the visual variant of Alzheimer's disease? So this was a googly, no? Googly or it's a bouncer. Totally it went up, up. I just hope it didn't shave your hair off. Right. So this is completely new. It's Benson's disease. Okay. It's called Benson's disease. B-E-N-S-O-N, Benson's disease. So the visual variant of Alzheimer's. Okay, so earlier there's another name called posterior cortical atrophy. So it's basically a problem of your visual cortex. Yeah. So posterior cortical atrophy, also called as Benson's disease. So here the patient, just like Alzheimer's, okay, so the patient cannot process what he's seeing. So he cannot read. Yes, he cannot read. So alexia, he looks at alphabets. He is not able to process what he sees. Yeah, so he is not able to read, alexia. Yeah, and if he can't process alphabets. He cannot process numbers also. So he cannot calculate. Acalculia. Okay, alexia, acalculia. And then he cannot recognize objects. Okay, so there is problem with visual recognition. Yeah, so there is kind of dressing, apraxia and all that. So remember, alexia is there, acalculia is there, and so there is a problem in visual processing and even the spatial orientation. So that is why this dressing sense and all is very difficult for them. Yeah. Yes, yes, Vinod. Okay. All right. Okay. So we finished all the 10 questions. Guys, today I have posted a neuro-ophthalmology question for you on Instagram. So please take a look, and evening there's an interesting post coming up for you. I hope you're liking the post and it's helping you revise. That is the whole point. And the test and discussion, I hope it's not very difficult. Guys, even if it is difficult, see, it has to be a mixture of easy and difficult in my tests, so that when you go for your NEETPG or INICET, you'll find it very, very, very easy. You'll be very confident. All right. Yeah, you're most welcome, guys. And to join our test and discussion program, you can ping us on the app. Okay. So I've given how to download the app. Just use the chat box on the app to ping, or you can directly WhatsApp me. You let me know, guys. And today's test, evening test, 6 p.m. test, quiz on the where is it? Telegram group. Yeah, on the Telegram group is Quint quiz. And tomorrow would be the discussion here at 11 a.m. Yeah. You're most welcome, Vinod. Yeah. Okay. All right. So if you need the schedule for the TND, please ping us on the app. So we can share it with you and you can join us. Okay. You're most welcome, guys. I'll see you all tomorrow. 11. Ciao. Have a good day.